Yeah, so my name is Lisa Climas. I think most people here are familiar with MastAttack. Is there anybody who's not familiar with MastAttack? You're not? Okay, great, yeah. So, so I started MastAttack about 5 years ago because it's so weird to think, it's such a long time ago, it feels like now, but so I introduced the mast cell community about six and a half years ago. And I'm a research scientist and molecular biologist. And when, I have systemic mastocytosis, it started to get more serious and I was, having more, issues with organ function, really severe GI issues. I started entering into these, these Facebook groups, right? And, people would ask questions and, it was one of those things where it was just like, there wasn't a MastAttack or a MastAttack group or whatever yet. And I would just answer these questions and I realized very quickly that this was, at that point in time, it was just very difficult for, for patients to interact with non-providers or, they see so many patients, especially if they're mast cell specialists. They see, so many patients come from all over the country and, and they just, a lot of patients had, were apprehensive, I guess, about things that maybe were not particularly worrisome, just because, when you don't have anybody to ask, is this a big deal? And for somebody to say no, it's not a big deal, you sort of wind yourself up in your head, right? And so I started answering these questions and quickly realized that this was a lot of people who had a lot of questions, okay? And so what I started doing was I started posting on Facebook every day on my Facebook account for Rare Disease Day, or the Rare Disease Month, February of 2014, just like a fact about mast cell disease every day. And that became very popular. And so then I started just putting these, I just opened MastAttack on Blogger or whatever, just so that there was, somewhere for everybody to go. It was easier than accepting all these friend requests, whatever. And it's sort of funny because if you can go back and all of those posts are still up. So it's really funny when you look back just to see how different, it's this is like a 4-sentence post. It's got there's no references. There's it's just very quick answers to these questions, as opposed to how it is now, where we have on MastAttack terms, we have posts that are written in lay terms for for patients or for providers, or even for other people, professionals for whom English is not their first language. And then we also have a number of journal style articles that are written either with references at the bottom or in text, so that you can take this to your providers and they can verify that all this information is correct. And sort of a weird entry into the mast cell world because it didn't occur to me. It's I don't even know why this is either, but it's it didn't occur to me right away that this disease could be dangerous, right? This is what a stupid thing to say, but it was I live in Boston, you know what I mean? It's I've been very fortunate, I get good healthcare there, and it sort of took some time for me to sort of realize, that oh, this is serious, I've not ever, I've never had anaphylactic shock, I've never had any of this stuff, and things I feel sort of got serious, in a hurry, and I feel if when I was sort of that person and I was sort of not necessarily new to this disease but new to this community, I think that if somebody had just, when I was sort of talking about this, and if there had just been somebody who had been through it, who had been it's gonna be okay. You know what I mean? We can answer your questions, it's gonna be okay. Sometimes it sucks, and this is what it is, and but it's not you can have a good life, whatever. That I think that my life would have been very different, and there were people like that for me later on, but I feel at that point in time it was just I just felt very alone, and I don't like to feel alone, and I don't like anybody else to feel like that either, so that's why I started MastAttack. And so MastAttack started formally in April of 2014, so yeah, just turned 5 years old, which is pretty nuts. So, okay, so I Here we go. Okay, great. So as for my background, so I'm a subject matter expert in mast cell disease. I'm sure you're all aware. So I have undergraduate degrees, biological sciences. My graduate degree is in biology with concentration in microbiology. So I was trained in infectious diseases and worked in infectious diseases microbiology for about 10 years. And so like if you Google, Lisa, I publish under my full name, Lisa William Clemens, you'll see that like I specialize in developing tests for like sepsis and bloodstream infections, which is why like when all of you are like, I have a bloodstream infection, I'm like, tell me, I need all the details, give me all the details, you know what I mean? Like right now, like can I do something? Like, do I know somebody? So I did that, and then so I left, it's sort of weird, but I left my job at that particular company, actually around the same time that my mast cell disease was getting really bad. I needed to have a whole bunch of GI surgery, and I had a colon resection, an ostomy placed, and just a lot of things happening. And I started a new job at Novartis, in their oncology division. And so what I was doing there was I was developing tests that were basically like for clinical trials, like how do I identify patients that are going to get like the most benefit out of this clinical trial before they're in this trial? You know what I mean? Or are there people who are not going to get any benefit so that we know that like they don't waste their time or whatever. So I started working there, and something I did not realize, again, it was like very shortly after that, the division that I was in absorbed the rare disease division. Okay, so it became oncology and rare disease. And this was happening at like the same time as my disease was getting really bad. And I was pretty recent like addition to that department. And I was literally walking down the hall one day, like talking to a coworker of mine about like my c-Kit, test your c-Kit D860V mutation test result, which is important if you're going to be diagnosed or treated for systemic mast. And this guy is walking this way towards me, and I'm like talking about this to my friend, and he literally like turns around and he was like, what are you talking about? And I was like, I was just like, and again, it's like, what person just like, just like immediately like blurts out, I've just had like this weird disease and like talking about my mutation test over here. But he was like, you have systemic mastocytosis? And I was like, I do. And he was like, you should walk with me for a minute. And I'm like, okay. So that guy, who later became my boss for 4 years, named Stefan Wong, oversaw the original Gleevec trial for systemic masto. He oversaw the Minister and Bride Act trials for systemic masto, and several other programs. And he helped me a lot. And so what I discovered, like in this conversation, was that not only did our division now support clinical trials for oncology, we now supported clinical trials for rare diseases, and one of them was the rare disease that I had. And I got very lucky, and in that I, as a professional, sort of dropped into this, just incredible group of people who like understood mast cell disease. Not like necessarily what it was like to live with it, but like understood sort of like the highlights of it. And in particular that like you can look fine and be fine, and then 10 minutes later, like, like not be fine, and, have it be serious. And, I got really lucky that, I had like sort of this background. I put myself through school. I worked all the way through school, put myself through school. So I worked in pharmacy for a long time, worked in compounding pharmacies before they made it like in Massachusetts, compounding techs, you couldn't compound anymore, but I was there before that. So my sort of relevant history is, biology degrees, biology graduate degree, worked in pharmacy for 10 years on, both sides. Developed tests looking for various things, and then supported tests specifically for oncology and rare diseases, and then later specifically for mast cell diseases. So I got very lucky because my company acknowledged that this was an unusual situation where typically when you work for a pharma organization or just a big research organization like this, you have to sign, tons of documents. I will not talk about this online, I won't talk about that online, and they generally will, it's like anything that they could ever have anything to do with. And, I said to them, I was like, I have a blog. And like, when I started the blog, I really thought it was gonna be like 5 people and my mom who like read this blog. And like, that's not what happened. And, and so, I went to my boss one day and I was like, like, what do I have to, like, do I have to take this down or what? And, you know, I mean, like, I had to talk to, like, their counsel and you know, all these different people and whatever. And I mean, they had to have, like, a very high level meeting about it. And they agreed that, you know, that this was an unusual situation and that to remove this information from the internet could affect the health of people that, you know, I knew, and also for people that I don't know, and could affect, you know, providers' ability to rapidly access information that will allow them to care for these patients. And so, you know, so they were really gracious about it. I mean, and they let me keep it up. They were extremely supportive. And, you know, the only, you know, real caveat was like, you can say anything you want. You can say anything you want about how you feel, as long as it's true. So, like, for things about, you know, I mean, I was allowed to, you know, talk about, you know, I mean, like, I've been on, I mean, plenty of drugs that make me feel like garbage, I'm sure everybody has, and, you know, it's like, it's, you know, I'm able to speak openly, and again, supported by this really great organization, and yeah, so, I mean, and now I'm here. And so I decided this, I have some very specific goals, right, that I decided last year, okay, that I'm gonna do. And so one of them is to put up an 8-session course about mast cell disease, which will be like sort of not beginners, you know, but sort of you know, mid-level mast cell stuff. So we're still working on that. It's gonna come later this year. Wanted to do a speaking tour. Yeah, so that'll be publicly available and free. For those courses will be publicly available and free, and all materials will be free. Yeah, I don't believe that you should have to pay to have access to healthcare. So I don't charge for anything. I mean, if people would like to make donations, you're certainly welcome to. If not, that's okay too. You know, I mean, this is not like a, you know, donating money to me is nice, and if you would like to, that's great, but it's not gonna, you don't get any help from me sooner, you don't get any help from me faster, I don't help you any better than I would help anybody else. And one of the big things that I'm really trying to do in the next couple of years is to make Lisa-Climas and MastAttack obsolete, okay? Like, there should not be a situation, you know, where we have, you know, the internet, and, you know, this information should be publicly available for everybody in a form that everybody can understand, you know? And so that's why we're doing things like, you know, like this course, like I basically wrote you know, not like a text for it, but like the 107 series, which is all in lay terms, is sort of like the entry into this course, right? So that it's, you know, it's easier to follow. And then now we're doing this speaking tour. And so I've spoken in Houston, I spoke in I spoke in Berkeley, technically, last week. I'm here, and I'm speaking in Philadelphia and like DC, Maryland, Northern Virginia. We're trying to find a site for that in the end of September. And then I'm planning to also speak in Denver this year, okay? And then hopefully some other places next year. So if there's, you know, a place that, you know, you think that community would like me to come and speak to them, let me know about it. And yeah, I'll see if I can make that work. So, okay. All right, so the title, okay, hold on. So just one more thing. So as you can tell, I'm not like, I don't know, like move around and like talk to people. I think it's easier than talking at people, right? So I'll start moving through this material that I have. If you have questions or if you have something that you want to say, put up your hand and I'll call on you and say it right now. Okay, I'm not, there will be time after this is done for like if you have questions about other things that's, you know, we can open it up too, but I just find this much more effective if like while you're talking about something, you know, you think it's easier to sort of, you know, find the connections, you know, and I think it's sort of just a better way to learn about things if you can just ask immediate questions. So I am profoundly deaf in my left ear and I have moderate to severe hearing loss in my right ear. So this room is actually very good because there's not really any background noise. I know there are some other people in this room who are, you know, hard of hearing or deaf as well. So please put your hand up if you have a question, because even in a room like this, if I'm not looking at you, I'm not, if I'm not looking at you, I may not realize that you're talking to me, okay? And so, so Amy, can you do me a favor? And if you see somebody's hand and I'm not, can you just like get my attention? Okay, great. So, all right, great. So the title of this talk is Yes, I Can React. Yes, I Can React to That: Managing Misconceptions About Mast Cell Disease. We all deal with this a lot. I think that this is, one of the most common questions I get, and it sort of comes in like different forms, but it's basically like, I saw insert, and not really like medical professional either. It's like, I saw Cindy at the laundromat, and she's like, you can't react, that's not how allergies work, and whatever, right? Like, we all deal with this sort of stuff. So, so one of the things that I wanted to talk about today is the fact that when you have mast cell disease, you can basically react to anything, right? And I think that we all know that, and I think that it's, we all know that, right, as a patient population, but, sort of the extent to what, to what you believe that as a provider, I think is sort of starting to, divide the, providers and their patients into sort of these different pools, right? So, so I want to talk about some things that there is, 100%, there's documentation for this, and again, if you've like I said, all of these, the slides will be up on my site. And if you want to email to yourself, that's fine, because all of these there's references for all of these, okay? So physical triggers for mast cell activation, okay, as described by urticaria. Okay, so urticaria is the fancy way to say what? Hives. Okay, good, yeah. All right, and so I find that when you're looking for, documentation or proof of something, a lot of times if you say, sunlight mast cell activation syndrome or whatever, you're not going to find anything, but if you can sort of pick out the specific symptoms that you have, so if it's like, sunlight urticaria or sunlight itching or, whatever, things like this, that it's, sort of older, larger pool, right, of like information, that you're likely to be able to find this in. And so we're be able to find supporting information. Okay, so injury to the skin, even minor, okay? It's a big physical trigger. And this is one of the reasons why use of blood tests can be contentious, on how accurate it is for certain mediators, because, in your skin, it's like, it's like 6 to 8% of the cells in, your germinal cells are immune cells, and most of those are mast cells. So it's like, and if you're a person who's got mast cell disease, especially if you're prone to rashes or if you have cutaneous mast cell, like you're gonna have a lot of, you're gonna have a lot of mast cells there, and they're gonna be, more prone to activity. So things like, breaking the skin for a blood draw, for getting an IV, if you have to do skin testing for allergens, like this is a big reason why, when people, show up in, the mast cell world, and they're like, oh my God, that my doctor said that I had, I find this actually happens more with children, but it's like I just took my son in, and their doctor says that he needs to get skin testing, he has mast cell disease and he needs to get tested, and it's like, what, no, stop right there. So, because mast cell patients have so many mast cells, in your skin, they're the likelihood of reacting to anything that touches them increases. But mast cell patients also have another common behavior, which is basically that, when you've, how sometimes, you bump something and you get a little welt here, and then next time you break out in hives, you get a little welt here, and it's like that, the same thing. It's because all of the mast cells in that area are primed, okay? And they were like, recently we had to do a very important thing where we got inflamed. Very important, always need to remember how to do this. When you need us, we will be here, okay? And, and so it just makes like, like the skin testing and stuff is for people with mast cell disease. It's worthless. And that's why like dermatographia, which is literally writing on the skin, right? I actually can't do this today, fortunately. But I'm sure if I went off my antihistamines for a few days, I certainly could. But yeah, so it's like, it's not necessarily that skin testing is dangerous, it's just not useful. You know what I mean? It's like, it's not reproducible. It's like if you do it today, you're gonna get a different, and then do it again the following week, you're gonna get like a different result. So unfortunately, it's not helpful for us to identify triggers. Another thing, as an aside about that, and just sort of things to be aware of about this, is that another thing that can cause some issues with skin testing is the fact that most offices tell you that you have to stop taking antihistamines. Okay, mast cell patients are not recommended to stop taking their antihistamines unless their mast cell specialist has told them to do that, okay? Like stopping our medications, you know, can be dangerous for us. And, you know, I mean, there are instances where, you know, your provider, I mean, knows what's best for you, and I mean, you have a relationship with them and you know your body. So, I mean, like, are there times where you should stop medications for a couple of days for tests? Absolutely, but that needs to have an involved conversation between you and a doctor who understands mast cell disease. Okay, right, great. So, yeah, so let's move on. So we're just talking about sunlight, so sort of like my original trigger. When I was diagnosed with mast cell disease, I had been, you know, like I'm sure everybody else here, been sick for a really long time. And I walked into this office at Brigham and Women's in Norton Greenberger, who was like, literally just pulls out a handwritten list, okay, of 9 things. And he goes, I have 9 questions for you. And I'm like, oh, okay, you know, and it was literally like one of those, is like, have you ever been described as having, what was it, sensitive or Irish skin? And I was like, yes, but I'm Irish. Like, you know, it's like, look at this, you know what I mean? It's like, come on. And it was really funny because like when he said it, I literally laughed and like he didn't think it was funny. You know, you could tell. It was like, I'm really sorry about that. Sorry about that. You know, but yeah, so it was like that was one of the things, is that like when you go into the sun, do you turn around and like, does everybody know? And he was like, I'm not talking about if you're in the sun for an hour. You know, I'm talking about like you walk outside 10 minutes later, you bright red, and it literally had never occurred to me that that's not what happened to other people. I just assumed that like you tanned like everybody else in my family, or like me, I just got like extra Irish skin or whatever, and like this is like what happened. Had no idea that this was like, you know, like a symptom of this disease. No idea. So something else that's also interesting about this. So this is called solar urticaria, is exactly what it sounds like, right? So you get hives from being in sunlight. And what's unusual about this too is that you know, there's different wavelengths of light, right? And, you know, some of those, you know, certain wavelengths or ranges are actually mast cell stabilizing. Okay, so they actually use these for people who have really severe cutaneous mastoma, or even for people who don't, but just have like really bad itching, and especially if they get like swelling and itching, like the angioedema, they'll use UVA, PUVA. They use PUVA treatment, but you know, but then like other treatments are like, you know, are activating. So it's interesting that, you know, it's not just sunlight. Yes.
I'm sorry, what is PUVA?
It's so PUVA. I can't remember what the P stands for, but it's ultraviolet.
Yeah.
A.
Oh, okay.
Yeah. But I can find. I think is it polarized?
So that sun sensitivity. So I have a sister and my mom both have lupus, but they seem to have like a bunch of symptoms of the mast cell stuff too.
Yeah.
Are they?
Yeah. So you can't. So that's an interesting question. So I actually have and was diagnosed many years before I was diagnosed with mast cell disease, with mixed connective tissue disease, which is typically a combination of rheumatoid arthritis, lupus, and scleroderma. So fortunately, I don't have any scleroderma markers. I do have markers for rheumatoid arthritis, and I have had markers for lupus in the past, but I don't have, at this point, all of the things that we really thought were linked to lupus in the past seem much more likely to be linked to mast cell disease. Right. So as for lupus, okay, so let's sort of a couple of things here. Okay, so the first is that mast cell disease is linked, I mean, not really systemic mastocytosis as much, but mast cell activation syndrome, monoclonal mast cell activation syndrome, things like this seem to be very closely linked to autoimmune disease, okay? And I mean, this makes sense in that, you know, if any part of your, you know, we don't think of your immune system as being like an organ, right? It's not a solid organ. But I think it's easier to conceptualize these things if you think of it as an organ, right? So it's like, instead of thinking it as all of these different like cells all over the place, just think of it as like one connected like a necklace, you know what I mean? It's like where you've got like lymph nodes, and you know what I mean? It's like, and these are all like, these like little pearls or whatever, and all of those, you know, and like along that necklace, they can like send messages to each other, they can talk to each other, and if you pull on one, you know, hard enough, eventually it could cause, you know, a different part to break or part to be strained, okay? So basically anytime you've got, immunogenic inflammation, it can cause mast cell inflammation. That does not mean, though, that it necessarily causes mast cell disease, okay? So like you can have, you know, let's say, for example, you have lupus, you've got, you know, you're having all of these, you know, now you're having anaphylaxis, you're having all of these like very, you know, you've got like the flushing, not the sunlight, not the butterfly rash, but, you know, like more classic, you know, red flushing and, I'm trying to think, you know, like low BP and just other things that are more typical of, you know, trouble with foods and things like that. So if you're having those, you know, it's possible that you've developed mast cell activation syndrome that is related to lupus. However, you know, it's also possible that, you know, your lupus could irritate your mast cells without necessarily causing mast cell activation syndrome, right? And what is that, right? I mean, this is sort of like what?
Another part, so
Yep.
you don't have to answer it now, you can answer it later, but I'm type 1 diabetic,
Yeah.
and then I started having anaphylaxis to
Yep.
every
Insulin?
single insulin injection.
Yep. Yeah.
And
Okay.
so I can't stop it because
Yeah, I know. We should. Yeah, let's talk after. Sorlin, the U for ultra, the V for violet, and the A is for the portion of solar spectrum between 320 and 400 nanometers in wavelength. Okay, sorlins are chemicals found in certain plants that have the ability to absorb ultraviolet light. There we go. Thanks, guys.
what did you want on
It's just write down your name and your email and that you're a type 1 diabetic who reacts to insulin. And we'll definitely follow up on that. I know a few other people.
Thank you.
Yes.
Just, when it comes to butterfly rash,
Yeah.
for lupus, you typically are sparing this fold
Yep.
versus mast cell activation syndrome. Yeah. The difference.
Yeah, but like it
That's
said, I
great.
have the butterfly thing, but I have this thing.
Yeah.
Okay.
Yeah, no, definitely. Thanks for clarifying that. All right.
Yeah.
Okay. Went through injury skin, sunlight, solar urticaria. Okay, vibration. Okay, this is probably the one that, yes?
No, just reading
Oh,
this.
sorry. No worries. Get yourself at home. We're just talking about vibratory angioedema. So of all the things that I think that patients say to their mast cell patients say to their providers, I think that the one that makes us sound like the kookiest is when something vibrates near me, I have symptoms from it. And yeah, and it's one of those things too where it's like, it does. I mean, it was like, I'm a scientist. I worked in medicine for a long time, and it's like I get it. Like I get, it's like if this didn't happen to me, I've said all the time to providers about mast cell disease, like if this didn't happen to me, I would not think that this was a real thing, but it did happen to me, and it is a real thing. And this is another one of those things. Like I'm fortunate that this, in particular, the vibratory angioedema and the urticaria doesn't affect me very much, but I've literally been standing next to a friend of mine on a train platform and watching as the train approaches, her face get redder and red, it's a real thing. And so the mechanism is not well understood. I think there is more, there are more case reports written about it, okay, which is not as comforting. But there is a fair amount of data written on vibratory angioedema as opposed to vibratory urticaria. So angioedema is, it's basically hives under your skin, right? So it's basically when you've got the swelling in between the tissues, if it's in the higher layers of your skin, it causes hives, and if it's deeper than that, it causes angioedema. And there's often a lot of, there's a very close relationship between the hiving, the urticaria, and angioedema. Like I said, because the mechanisms can be similar. Something else with vibratory angioedema is that more than other symptoms, well, so we all know that these mast cell diseases can be hereditary, right? And it's this has now been, there's now enough people that, who don't know each other, that aren't in this cult of convincing, trying to, convince practitioners that this, condition is, familial when it's in fact not. It's like, this is definitely something that's real. But something that is funny though, is that for people who have really strong like vibratory reactions, that seems to be a very clear trend with, in my experience, all of the people in their family who have mast cell disease. And I don't know what the reason for that is. It could just be a sampling error. It could just be that that just happens in the people that I know, and I'm more likely to hear from their family members because they know me. But yeah. So that's often a strong trend in families. So for people who are looking for data to provide to their providers, I would recommend that they search vibratory angioedema, and there is some data on that online. It's definitely not as strong as other causes, but yes.
I'm wondering if it's the same kind of vibrations, but I have issues, and I only know this because the TV was too loud for me to hear.
Mm-hmm.
But whenever a prop plane goes over, like especially in Miramar area, that does something to the atmosphere, where I'm just instantly.
Yeah, I don't know if that would be more of an effect of, like, barometric pressure is definitely something, that can also cause an issue. I mean, like, I would assume it would also cause, if you have, issues with vibration.
Well, but even in elevators today, because I went up to like a 36th floor too many times, and all of a sudden it was more dysautonomia.
Yeah, sure. Yeah. Hold on a second. You're good.
I've read somewhere about a link between vibration in the magnetic field, which causes compression, which causes mast cell activation.
Yeah. So it's this is one of those topics where I think that the problem is actually not that there isn't an obvious cause, it's that I feel like there's a lot of obvious causes, and because we've sort of like gotten this far into, living on this planet, and without being aware of these causes, that people seem that, people just, I think that sort of makes people think that it's rare, and I think what's actually happening is that it's common, it's just not reported as being, you know what I mean? It's just something that like you just like assume is, like this is just like part of being alive. So as far as the magnetism goes, so I have seen some papers on that. I haven't seen something on magnetism is particularly compelling. However, what I have seen is, and that makes sense to me, is, it's like if you if you grab something and you shake it, it's like if you grab, like a orange juice, you know what I mean, and you shake it, it's like it's gonna, hit the sides of it, right? I mean, so it's like, it's gonna, it's like if you think about like that being your body, if something changes the way that things move around in your body, even for a short amount of time, it's gonna press up against your skin or against your organ or something, and it could pop, right? And so this is one of the reasons that like pressure urticaria is very common for mast cell patients, is that it's like you're literally like, how like when you put like the ice packs on the floor that have like the little bag and you step on it, it's like that's what happens. That's what pressure urticaria is, or pressure reactions are. It's you're popping your mast cell, and these like chemicals are coming out. Yeah. And so, like you were saying before about like, is this magnetism? There's a lot of things, and I think that it absolutely could be magnetism. I think that like metal concentration is also something that's possibly very linked, but I think that it's actually that that this just happens. These are just things that we just take for granted as being normal, instead of realizing that these are discrete functions that, when they happen more seriously, can be more dangerous for people. Yes.
So while we're on the topic of unusual triggers,
Yes.
one of the things that has always struck me is altitude, barometric pressure are really fairly common symptoms.
Yep.
So for instance, when I go to see my beloved mast cell doctor and I walk in the door, the first thing he says is, how's the weather treating you? So he knows this. What's connected to that? And I've done some literature researches, not exhaustive. There's actually not a lot on that.
Yeah.
But one of the things that is a little bit further removed from that, but seems related, is moon phases.
Yeah.
So atmospheric pressure that changes in relation to changes in the moon phases. We all know that there is this folklore and observation and data from ERs and from mental health providers.
Yeah,
All
absolutely.
sorts of data sources that tell us that certain phenomena increase at certain phases of the moon. We know about catamenial epilepsy. What is there that you may have ever found in the literature that ties that back to mast cells? Anything?
I mean, I think that the obvious link is that, you know, I mean, like that hormones change, I mean, on this cycle, or try to change on that cycle, okay, which is, I think, is important to consider. Like when you're having, you know, conditions that are in some way hormone related, it's not necessarily just that you sort of consider that your body basically wants these, especially not just for sex hormones, but larger sex hormones, I mean, like that's sort of like the archetype here, is that like in order for your body to like be in homeostasis, so homeostasis is basically your body's ability to keep things functioning at the same normal level regardless of like what happens to it outside, okay? So a big part of your body's ability to achieve and maintain homeostasis is the idea that it wants these things to be cycling every 28 days, okay? So if that's not happening, it means that there's a strain on your body somewhere, okay? And so it's interesting because for, you know, for mast cell patients who menstruate, it's sort of interesting because I don't think that I know a mast cell patient who's a woman or excuse me, not just a woman, but I mean mast cell patient who menstruates, that, you know, that has, you know, sort of like this regular cycle, right? Where it's like where it's always predictable, right? And it's funny, when patients are able to get better control, mast cell patients are able to get better control around the menstrual cycling, it also often helps to alleviate other symptoms, right? So, I mean, for me, that would be the most obvious link to, you know, to the moon cycle. And I would also guess that, I mean, like in communities, especially on like tidal communities and on the ocean, that, I mean, it changed. I mean, like I grew up in Boston. If I walk for 10 minutes in any direction, I hit the ocean, you know? I mean, it's, you know, we have some unusual weather effects, you know, like near the water, and especially when, you know, when there's a full moon. And that definitely plays, I mean, like, and not just mental health either, but I mean, mental health is definitely part of it. But as an aside, a lot of, so you're talking before, but you know, we have all of these data, you know, from ERs and mental health providers, and, you know, that it gets worse around the full moon, absolutely does. One of my uncles is paranoid schizophrenic, and he would get real paranoid, I mean, like around the full moon. So what was interesting to me is that like when I was in my 20s and really like when I started working in pharmacy when I was 19, and you know, over time I started becoming really interested in like all of these medications and like how do these things work and, you know, whatever, and realized that the vast majority of you know, of quick-acting psychiatric medications and also long-acting psychiatric medications have at least some amount of antihistamine ability. So, like, when you look at, like, atypical antipsychotics or tetracyclics or tricyclics, those are all antihistamines. And you know, so, like, if you're going, you know, or, you know, benzos, which are not antihistamines, but have secondary effects that can cause it to be, you know, they're not, we call them mast cell stabilizing, and I don't think it's a great idea to use that term because I think that means a very specific thing. However, I do think that that benzodiazepines certainly help alleviate allergic symptoms and mast cell symptoms. I just think it's a little bit different than stabilizing it, which is the term stabilizer basically means that it prevents the mast cell from being able to release mediators beyond the cell into the environment. But yeah, so I mean, it's like how we sort of deal with, you know, psychiatric symptoms in large part is by managing histamine, free histamine, the body's ability to release histamine. and the body's ability to to have those, other similar chemicals, be secreted into other environments. And of course, histamine is very closely related to dopamine, and you've got like epinephrine and norepinephrine, and just all of these hormones. And the thing about hormones is that they are like they take a long time to work. So you've basically got like this sort of two communication systems in your bodies. You've got your nervous system, right? So your nervous system is like it happens fast, and you see the effect now. Okay, so it's mostly electrical. Like I start an impulse here, and it connects to all these other things in a line, and then you feel it at the end of the line, and it happens right now. Okay. As opposed with hormones, it's much more complicated, right? So, but in the same way that it's much more complicated, it takes longer to work, but the effects are much farther reaching. You know what I mean? This is why, like, when you have, really any endocrine disease, you often have to manage it for life. You're talking about diabetes, and it's because it's these hormones affect so many things in your body. And so I think that ultimately that's what I would expect the link to be between the sort of full moon and mast cell symptoms. I also think that there's definitely other possibilities. I'm certainly open to suggestions. Yes.
I have a question on that. I definitely agree with the full moon. My neurologist, for me, it causes migraines.
Yep.
So bad, and I had nicknamed them tidal headaches.
No.
Because that's what I just feel like that does. And speaking of familia, so I'm MCAS, and my daughter was diagnosed cutaneous as an infant, and now at 19 is systemic. So, but her reactions will go really extreme into.
Hold on
I
one
think that's
second.
too bright.
Yeah. Can we?
Suzanne, too bright.
Okay. Can we maybe put up the blinds? Maybe the blinds will be easier.
I will work on that, and it would be better for most of us.
Okay. I just want to make sure, hold on, I'm going to turn around and finish this. I just want to turn this back on. Yeah, I just want to, I know the ultraviolet light, it's going to be hard for some people.
It just seemed like it was starting to get a little.
Yeah, it is, for sure.
Yeah, and I recently learned.
Yes.
I recently learned that taking Benadryl is the best drug I can take for my migraines.
Yeah.
So I learned that in the ER. I took my daughter in for one, and they gave her 100 milligrams like Benadryl. And I was like, wait, they're like, oh, that's always in the migraine cocktail. And I went, really?
Yeah.
So putting that in has helped. In fact, took one about 45 minutes ago, and I'm finally getting over a headache. But her reactions, if we go into altitude, or she has something that's really triggered, she'll go into fainting and or seizures. Does have POTS, but the seizures we've never figured out. All EGs, all tests have always been normal. MRIs, everybody chalks it off to the mast cell. Kind of like when they can't figure it out. All her doctors have always just said blame it on the mastome. I don't know what the research is like. Is that just because it won't be during a reaction?
Well, the headache.
No, the seizures.
Oh, the seizures,
Like it won't be because she's flushing, or
We don't really know.
but it will because we went up too high in altitude, or she was sick a day or two before.
Yeah.
Or is it just the system out of
We
whack?
don't really know. Unfortunately, it's like, I think at this point, it's, I started really seriously looking into this. It's not a problem that I've ever had, okay? And so it's not something I had really experienced much until I took on this. One of my first cases that I took on was 4. Yeah, she just turned 4. And she had really, really severe true systemic masto. She just had all this like nightmare. So she went on, I'm very close to her mom. Mom was talking about me, talking about her case. Her name is Izzy Edelman, for people who follow her case in the book. And she was like, she got airlifted from Oklahoma, University of Oklahoma Oklahoma Children's Hospital to Boston. And that was where I met them in person, and she was like shocking, you know, like 2 to 3 times a week, she couldn't eat, and she was having these seizures. And what's really weird though is that, so Izzy was born having seizures, and she didn't have, I mean, really noticeable mast cell symptoms until she was about 2. So she was having, so she had an epilepsy diagnosis, I mean, for years before that, and had been on anticonvulsants, and I mean, for like a long time. And, you know, as time went on, it was like, it seemed easier, like you were saying, where it's like, we could sort of like, it's not that we couldn't like predict, but like if we like journaled like her stuff, it was like we could look back and be like, oh, you know, X traumatic thing happened to her on this day, and then 2 days later, you know, whatever, the seizure. But so for me, the weirdest part of this whole story is, so Izzy, for people who don't know, needed to have a bone marrow transplant because she had an unrelated blood disorder that was killing her. And so she, you know, she already had to have the transplant or she was gonna die. And I mean, and honestly, things didn't look that great with the transplant either. But she was already assuming the risk, and her team was really good about, I mean, they were, you know, I mean, I talked to them, I was like, look, if she's already assuming all of the risk of having a bone marrow transplant, like, can we not just try, just, you know, just do all of it at once? Like, can you, you know, are you guys like open to that? Like, can we work towards that? And they were great. I mean, and it was like, it took a long time. It wasn't just, I mean, like, of course, I wasn't like the one person involved in this process, but, you know, I mean, it's like there were, you know, several of us and tried to, you know, use protocols that are used in, you know, transplant, bone marrow transplant, HSCT for people in, you know, experimental trials where they're trying to eradicate their malignant systemic mastocytosis. And so Izzy had, prior to the transplant, she had flagrant systemic mastocytosis. She had HLH, so hemophagocytic lymphohistiocytosis, which is a different, one of her other immune cells was literally chewing up her blood cell, literally eating her blood cells and releasing the iron. So she would have sudden severe, like iron, like high, like heavy metal, like, I mean, it was so bizarre reactions. And GI bleeds, the whole thing. She also had primary immune deficiency, and she had diagnosis of epilepsy. Okay, that started 2 years before she had mast cell disease, which was like multiple biopsies, was definitely systemic masto, met all the criteria for adult systemic masto. She had her transplant, all of them went away, including the epilepsy. Yeah. And they have no idea why. Yeah, she lives like a completely normal life now. Like I saw her in January. It's like a picture of us, like, you know, on the block hanging out, which is like, you know, like this is the dream, you know. But no, I think of her a lot. Like when people, you know, it's like things are not always related. I think, you know what I mean. It's like, but you know, like we're a closed system here. You know what I mean. It's like, that's not a good way to say it. It's more, it's not that. You know, when we have multiple conditions, it's not always that one of those is causative of another condition. I mean, if they're sort of like in you together, then they like affect each other. But, you know, this idea that like, you know, whether or not they sort of started in different places, they're both in you now. You know what I mean? And so like, whether or not like, you know, you have, you know, migraines and you have, you know, MCAS or whatever, it's like whether or not the migraines cause, you know, MCAS cause or whatever. It's like if the migraines are a symptom of your MCAS, they're affecting each other now, you know. And so I think that's something that is helpful to remember when you know, when you try to sort of think of yourself as like a whole being, right? You know what I mean? That, you know, it's like the fact that these are different organ systems or different molecules or different diseases, you know, doesn't mean that whether or not they all started in the same place doesn't mean that they're, you know, that they're all going to end up in a different place or, you know.
Yeah, the neurologist ended up saying, as long as there wasn't a bad, they had never put her on an anticonvulsant.
Yeah.
They just said, because they don't want to do
That's right,
that with
yep.
a normal
Yep.
test, and said as long as there is some kind of a fever,
Yep.
something you guys can pinpoint within 72 hours of them, we're just going to
Yep.
say that's her.
Yep.
Okay.
Yeah. Yep. I mean, it's unfortunately it's not, you know, it's hard to, you know, I mean, and as a provider too, I mean, it's like when you're working with rare patients, you know what I mean? It's like it's from a leap of faith, you know what I mean? Sometimes, and it's like you want to help people as much as possible, but it's also important to remember that, a lot of times it's like even very experienced providers are figuring this out with you know what I mean? And yeah, I mean, it's like, I'm a big believer in journaling, and you know, that has helped me figure out a lot of things, not just on myself, but like, you know, for patients and cases I've worked on, you know, and sometimes it takes a long time. Sometimes you don't see a pattern for a while, you know, but, you know, just, you know, I'm a big believer that, you know, whether or not we see these things as, you know, distinct conditions, you know what I mean? It's like they can affect each other, right? And so if you're having something, you know, that's happening in your body that's unusual, I think it's worth paying attention to that, and just kind of paying attention to everything else in your body as well that may be experiencing something unusual. Okay, so we just talked a little bit about, we talked earlier about pressure urticaria and angioedema. So basically, like we were saying, you know, it's like you're sort of like stepping on, you know, when you've got pressure underneath your skin, sort of pushes on your mast cells and pops them, and molecules come out, your mediators come out. Something about pressure urticaria and angioedema is that that's often delayed 12 to 24 hours, even in mast cell patients, which I find is really funny. And so, like, the classic reaction here is that, like, you know, they'll carry like a heavy purse like around all day, and then they'll like put it down, and then they'll wake up the next day and they'll have like their entire, you know, like their arm or like where the strap was or over here is like, you know, and they're like, I don't understand what it is, and it's, you know, when they look more carefully, they often will discover later that it's from the pressure of carrying the bag. Yeah, sorry, that's somebody was talking to me. Aquagenic urticaria, okay, water. Yes, you can react to water. Okay, so first of all, reaction to water is not a function of water temperature. This has been tested a million times by a number of researchers who I think have been very motivated to find that the reaction was to the temperature of the water. It's not, unfortunately. I would say that I get 3 to 5 providers every month who ask, providers I don't know, who ask me if it's possible to react to water. And it's one of those things where it's like, yeah, I mean, but it's like, it's again, like we were talking about, it's, you know, it's like when you're, you know, sharing the container with something else, right? It's like, you know, all these things sort of influence each other. So I mean, is it, you know, the amount of water? Is it, you know, is it affecting your pods? Is it, you know, is it your hormone levels? Is it the plastic the water's in? Is it how the water's sterilized? Like, you know, you can react to just about anything. And so in terms of, you know, if you're looking for, you know, just easy, you know, something easy to give to a provider when they're like, you can't react to water, you can just like literally just give it to them. It's called aquagenic urticaria, AQUAGENIC urticaria. And it's like well established, is a function of mast cells, has been tested 100 times. Don't argue about it, just agree. Temperature, well, yeah, don't argue about it. I say this like this is super easy. Like when you finally like have this information that you're not going to be like, guess what I have, you know. But you know, I mean, when you can, you know, educate instead of, you know, have a confrontation, definitely is better for everybody. And I mean, it's better for you too. So, okay, temperature extremes, cold urticaria, heat-induced urticaria. This is another one of those things that is like, these are, you know, you can get really hot, you can get really cold, it affects bathing, hot temperatures, ambient weather. It can, you know, I think that we forget a lot that we sort of have this like temperature in our body that like our body wants us to be. And so for a lot of people who have like really bad oral symptoms or sinus symptoms or upper GI symptoms, a lot of times the temperature of the food that they're eating or the things that they're drinking or medication or whatever being too hot or too cold or washed down something's too hot or too cold can trigger symptoms too. So that's worth considering. And in some of those instances, you can sort of get around this by, I mean, like just using, you know, like I can't remember the word for this. It's like tepid water, or, you know, whatever. Just drinking something that's not, you know, sort of like in the middle, not too hot or too cold. But there are some instances where, especially if it's liquids, if you change how salty something is. It's like that, you know, it sort of affects the way that the fluid interacts with your cells. So, I mean, for me, the obvious thing is just not drink things that are super hot or super cold, or food that's not super hot or super cold. But, you know, if you guys are having trouble eating or drinking, and if you have like dry cough, or you constantly feel like your sinuses are congested or swollen or whatever, it's something that is sometimes you can take that action and resolve some of your symptoms.
Can I ask you a question?
Yeah.
I noticed that you can drink a cup of coffee.
Yeah. I can.
Well, that's astonishing.
Yes, it is astonishing. It's really funny too, because it's like, this is one of those things that like, so when I was diagnosed in 2012 with MCAS, and then next year had, just a nightmare of like GI issues, repeat biopsies. I needed to have major surgery. I was diagnosed with systemic masto. So up to that point, I got through surgery fine, had like really no, I could eat cherries, there was a couple other things, but not like anything that was I had never needed like an antihypertensive. And nothing even that really up to that point I had classified as like severe anaphylaxis. And then in 2014, I went low histamine, and I went really strict low histamine, and for my doctor's suggestion, and I did it for 30 days, and they did blood work and urinary testing for mediators for immediately before and immediately after that, and then they basically were like, okay, well we did this, like you could go back and just, I wasn't having any serious symptoms that were attributed to food before that, and I couldn't go back, and I had lost my ability to eat most of my foods. And so this is something you should be really careful about. Is that it's you can.
You lost the ability after you did a low histamine dose?
Yeah. So anything that I had avoided. So for example, I was eating, I don't know, a cheeseburger or something. You know what I mean? It's like things that are chicken fingers, like things that I would eat regularly. It's like I went a month without eating these things, and it was like, this is really stringent. So I used the one that's on the Massachusetts of Canada, Society of Canada website, and that was what I did. And then when I tried to work backwards, it just my body just freaked out. And at that point, I had very flagrant mast cell disease, and it's like if I could go back and do this again, I think I would have saved myself several years of trouble by not doing that. But I didn't know. It didn't occur to me that what would happen would be that the reason that I tolerated these things was just because I had become deconditioned, or conditioned to them, and so I continued to lose foods for several years, and in 2016, I developed really severe vasculitis and lost a ton of weight. I lost 25, 30 pounds in 6 weeks. I lost all solids, and I could only eat could only tolerate 5 or 6 ingredients, and they were liquid. And I was a week from TPN, and we had discussed trying Xolair before. And so Xolair is a monoclonal antibody. So it integrates with the function of IgE. Okay, so IgE is sort of this traditional allergy molecule, right? And we know that IgE does something in mast cell disease, but it's not sort of what we know what it does in other allergy, sort of frameworks. So we're not really sure exactly how it works, but there, have been a number of case reports up to this point about the fact that, sometimes people, for some reason, who have really bad mast cell mediated GI symptoms, when they take Xolair, that it alleviates a lot of those symptoms for them. And, my doctors and I were talking about it, and I was just like, okay. We talked about it before. There wasn't a lot. I'm a scientist. I want to see the data, right? And there just really isn't any. And so finally, I was like, all right. I'd rather try this than start on on TPN or, you know, any of these other, you know, other options that I don't want. And so I started Xolair, it was either the last week of February, the first week of March, in 2017, and 2 days later I could eat solids, and I now, the only foods that I can't eat are fish, shellfish, and I can't eat alcohol, and I can't be around the smell of bleach. I literally can eat anything I want. Anything I want.
You're continuing on looking.
Yeah. Yep. Yeah, I get it once a month.
Wow.
It was incredible. Yes.
Because if you can drink coffee,
Yeah. Yes.
that's.
I know. I swear to God, I didn't bring these in here as like, I'm just gonna like, you know, I'm not like being paid by like, you know, the makers of Xolair, but no, I mean, it really is. I mean, like, I've talked about it a lot, and I mean, like, for my friends who are, I mean, like, Sean Michael must remember this. I mean, it's like, I've known a lot of you guys for a long time. And, like, you guys must remember this. I went from being like, this is a disaster, like, cannot get enough calories into my body, 2 to 3 liters of fluids a day of, like, you know, PPN, I mean, all this stuff to, like, you know, I gained back to, like, a normal weight in 8 weeks. I went back to work, you know, I mean, like, I was out of work for, you know, for 3 months with this, and I mean, I was able to go back to work. It was pretty incredible. Hold on one second. Yes.
Are there any cases where Xolair is recommended not to be continued if it makes all of the symptoms worse in the beginning?
Yeah, so typically what they, typically the reason they stop in the beginning, or I mean really at any point, is if it causes anaphylaxis. I'm not aware of providers where, I'm not aware of any cases where the patient or the provider have wanted to discontinue the use of it unless they've had, you know, flagrant anaphylactic symptoms. Because I mean, anaphylaxis is an increased risk for most monoclonal antibodies, regardless of you know, what its function is going to be in the body. But I can't think of an instance now where it's been stopped for a reason. Is there a specific case or something that you've got in mind?
I started Xolair 3 months ago,
Okay.
and my asthma attacks started increasing to very sudden and very quick, just not breathing.
Okay, you know, they may have thought that was, you know, one feature of it, you know, just a different presentation of anaphylaxis.
Yeah,
Yeah, sure.
and then my GI symptoms, I'm completely off all food and liquid.
Right.
So this is new
You
for me.
penny?
I'm penny.
Yeah. Yeah, so you're saying this is new for you?
A lot of new things since the Xolair,
Yeah.
it's just, I don't know, I mean, everyone says just stick with it.
Well, no, I mean, right. I mean, it's like, it's easy to say stick with it, but, you know, they're the ones who can't breathe when they're taking it, right, you know? And it's like, yeah, sure. I mean, like, there are, I'm sorry, I'm not trying to, like, you know, just, you know, I just think it's just, people often say, you know, it's easy for people to say things about, like, you know, your health, but it's not, I'm not in any way trying to mock you or imply that this is funny. It's just, I think that people just don't appreciate sometimes that it's like, you know, if it's not, it's still real even if it's not happening to them, right? Yeah, no, I mean, for things that, you know, like, yeah, I mean, for something that increased, like, it's interesting too, because, I mean, the original indication for Xolair, the not the one it was approved for, but the one that it was designed for was to make peanut allergic kids be able to eat peanuts. So I'll get to you in just 1 second. And so that's what it actually was for. And so there's lots of data on that sort of thing. And but the original approved indication was for IgE-mediated asthma. So do you have IgE-mediated asthma?
It's just asthma.
Just asthma? Okay.
Before.
So I would be interested to see if it's caused, like if you have, you know, IgE dust mites or something, and that's what's causing, you know, like if it causes kind of disturbance with the IgE molecules for that, like if it causes a trigger. I think that it might be helpful to know that. Yeah, I mean, it's kind of hard to say without having more information. And I mean, I know a little bit more about your piece that we can talk about after. You don't want to share your personal details about, you know, I mean, like just like in this room full of people. But yeah, no. I mean, it's like for me, it's like I say, you know, don't stop with anaphylaxis results, but you know, not being able to breathe, you know, low blood pressure, you know what I mean? It's like these are you know, whether or not they're sort of happening because of anaphylaxis, it's sort of level of symptoms, right? You know what I mean? That it's like, it's not safe to do those, you know, if that's sort of the outcome, I guess it doesn't really matter what the cause is. I'm just gonna go into this one, so I'll come back to you, yes?
I just want to say, since we're on the topic of Xolair,
Yep.
I've been on Xolair for 16 years.
Yep. You like it?
I
Has it helped you?
I was put on it for asthma, severe asthma.
Sure.
And I think it did help that, but then I was diagnosed with mast cell probably about a year and a half ago.
Mm-hmm.
And since then, it really hasn't been doing as much as it used to.
Do you think that it's maybe because of some of the other medications that you're on? Have you started a number of new medications?
In the last year, yeah.
Yeah.
It's hard to say.
Yeah.
I know it did work a lot back then.
Sure.
And that's why I stayed on it
Yeah.
so many years.
Yeah, sure. Yeah, I mean, that's a lot. I mean, like, if you were on it for 16 years, you were on it when it was in clinical trial. You were one of the original trial patients. Yeah.
I think I was one of the first people on it. And
Yeah.
we actually did skin cancer screenings and some other types of cancers. You had to take tests every few months.
Mhm.
They actually paid me for it too.
Yeah,
It was
right.
Very nice.
Yeah, it was nice, right?
Yeah.
Do you know, I mean, you know, how often does that, you know, do you sort of get money coming your way in this, you know, medical system, right? So, you know, so yeah, it's really interesting. So, yes.
I also started Xolair about the same time as you. Primary angioedema and GI symptoms my
Yep.
entire life for my kids and my grandkids. I've improved. I don't eat as much as you now,
Yeah.
but I do eat substantially more items
Yeah.
than I have the past decade.
Yeah.
My question is not about Xolair. It is kind of ties into what she was saying, and that is, in my experience, I'm 54 now. I've gone through so many years without diagnosis where I adapted
Mm-hmm.
and I kept going on until I couldn't in my 30s and 40s.
Mm-hmm.
In your opinion or research, do mast cells adapt to stop working to certain medications that are working? You know, it's unknown when, but can they just stop working for that, or is it just a change in the immune system that makes them stop working? It's hard for me to understand why certain things work and then that stop.
Yeah, I think that it's so, I mean, yeah, mast cells are extremely adaptable. I mean, like when you look in terms of, I mean, just your cells in general, I mean, probably the most tolerant, by which I mean most tolerant to change. That doesn't mean tolerant like you're gonna like having them in your body, but like tolerant like mast cells will still be here when there's nothing else here. You know, it's like one of the things that has, you know, that makes you know, mast cell research really complicated is the fact that, you know, mast cells live a long time, and they're very sensitive to what happens around them, very close around them, and so, you know, you can get, you know, take a biopsy and say you've got, you know, 500 mast cells in there, and even in that little space, you know, there are gonna be differences in like what is, you know, like what mediators they're making, what mediators are in their granules, like what receptors are, you know, are they expressing? So like these are like, so like if you've got receptors, you know, out on your cells, it's like what sorts of signals am I looking for, right? You know, from the body. It could be, you know, it could be a molecule, like I'm looking for histamine, or it could be I'm waiting for this nerve to tell me that it's hot, or, you know, whatever. So mast cells are adaptable and survivable in a way that really most other cells in our body are not. And mast cells also live for years. I mean, that's very unusual. You know, like in, you know, I mean, not just in the human body, but in other mammalian bodies. And up to this point, there has never been any evidence of a mammal without mast cells. I mean, like we use them to do things. I mean, part of part of what makes mast cell disease so frustrating and very difficult to treat is the fact that, you know, it's not like a cancer where it's like we can just like try and kill it, because we need mast cells to do things for us. We need them. Like we don't understand all of the things that they do for us. And even what we do understand, if we try to replicate it from a different source, it doesn't work as well. You know what I mean? And so this is what's hard, is that like, you know, it's like when we mast cells are involved in eating. So it's like when you're having reactions, it may not be that you're reacting to food, it might be that you're eating. Like you're literally reacting to the process of eating. That's what I reacted to. And it could be that you react to like temperature, and you react to, sunlight, or you react to falling to sleep, or, menstruate, or whatever, standing up, taking a shower. And yes, Dr. Abrams, there's something you'd like to say over there? No?
No, you sound like me.
Yeah.
And my appointments.
Yeah.
Like,
Yeah.
he's not gonna fall asleep.
Yeah.
He's not gonna eat it.
Yeah. And no, I mean, it's that, like, and the other thing too is that, people talk about, like, I'm a very emotional person. I mean, I think I was like that regardless of what my mast cells were doing. But, I also think that people forget them, like, when you say, like, oh, like, I noticed that, like, I have, like, if I get really mad, I have reactions. Like, you say that to a provider that doesn't really, really to anybody who doesn't really understand mast cells, it sounds like this is like a weakness, right? I mean, that this is like a sign that, like, you're sort of like not all together. And it's like, no, it's like your emotions do things in your body for you. You know what I mean? It's like, these are neurologic signals to your body to let, you know what I mean? And it's like, that's why, like when you're, when you get really scared, your heart beats really fast. You know what I mean? It's like, that's not because, like, you're, a weak person who can't control, you know what I mean? Like, can't control themselves, or is like causing, you know what I mean? Is like, makes themselves have these symptoms or whatever. It's because it's like, that's what your body needs to do for you to be able to run away from, you know what I mean? And, and so that's also something too. And I think that people in my experience, and it's certainly not like, it can be a painful process, but honestly, like, a lot of my stability is not a good word, I'm not stable. A lot of my sort of that's not a good word, my sort of like ability to like keep going, just sort of like keep going, my longevity, or whatever you want to call that. It's like, what do you say? Resilience. That's a good, yes, that's good. Resilience. It's a good sign. Has been helped by the fact that, I've had to do, like, a lot of, really intense emotional work on myself. And, that's not easy to do. And it's hard, and especially, because, it's like, we still live in a society where there's, like, a stigma, or against, like, seeing a therapist and, whatever. And it's like, these are, like I said, it's like, this is part of your body, you know what I mean? It's like these, emotions are symptoms, you know what I mean? And like, if you can understand why you're having these symptoms and you can work through them and manage them, and you can live a happier life, why wouldn't you? And especially in, conditions like mast cell disease where, unfortunately, it's like, I've literally had to say to patients, like, I know that this is really upsetting for you, but you have to stop talking about this because I'm afraid you're going to injure yourself. Not like I'm afraid you're going to self-injure, but like your mast cell disease is going to injure you, you know what I mean? And, it's like I meditate. I think I've seen a number of therapists over the years. I try very hard to be, to keep open with, communication with, family and friends. And, I think that that's something that's really important too. But, one of the nice things though is that you can sort of teach your mast cells though. Like if you sort of do this work over time, not just like emotion work or meditation, which is helpful, but these other changes that like we were talking about, like if you can make changes slowly, I think another good example. Like for you, like a reconditioning program. Okay, so I did a 12-week reconditioning program in 2015 after I had major GI surgery, and it was so effective. I went back to work. I was working 30 hours a week on site. I no longer met the criteria for POTS. It was because I had, sort of done like this very specific thing that worked for me. So anytime you can sort of teach your body to accept something a little bit at a time, it will become more tolerant. And mast cells typically like that sort of thing too. And like just like people, nobody likes to have like, a big surprise. Mast cells don't like surprises either. So yes.
So we have all these comorbidities.
Yes.
And one of the ones that you've taught me about that I have found to be interesting and helpful and not typically diagnosed by our mast cell specialists or explored by them is adrenal insufficiency and the whole HPA access dysregulation thing.
Yeah.
So I was lucky enough to be diagnosed, but I was diagnosed because one of my practitioners said, hey, let's test this.
Yeah.
And I turned out to have adrenal insufficiency, and treating that has brought a lot of stability
Yeah.
to my mast
Yeah,
cells.
it makes a big difference, yeah.
I was wondering if you could touch on that a little bit.
Yeah, sure. So adrenal insufficiency is, I mean, basically the catch-all term for any time your body does not make enough cortisol. And so cortisol is sort of the archetypal stress hormone. It's what we, like hydrocortisone and, methylprednisolone and all of these are similar to cortisol. And, we think of them as stress hormones, and they are, but they really have like very, far-reaching implications. And so as we talked before about the hormones, the HPA access. So the HPA access is the term, so it's hypothalamus, pituitary, adrenal access. And so what that means is that there's like if your hypothalamus, up here near the bottom of your brain, and that releases a hormone that then interacts with your pituitary, and then that releases another hormone that goes to your adrenals, tells your adrenals to make cortisol. And so there are multiple other hormones. So it's CRH, right, corticotropin releasing hormone, is from the hypothalamus to pituitary, and the pituitary is ACTH, and that's what tells your adrenals make cortisol. So the relationship between adrenal insufficiency and mast cell disease, or between cortisol and mast cells just in general, is very complicated, okay, and very complicated. And so basically, when you have adrenal insufficiency, it just means your body's not making enough of this hormone, okay? And that hormone being cortisol, you use cortisol to like everything. And so like anytime like you have any type of stress event, I mean, if you have like get into a car accident, your body makes more, stress hormone, makes more cortisol because it knows that you have physical injuries, or like if you are, if you're afraid of something, like, you think like you might have to run away, your body makes more cortisol, okay? And your body also makes cortisol at all these different times for you, okay? And it's like, the level goes up and down, and it's typically highest in the waking hours of the morning, so I think it's 6 to 8, or 6 to, I think it's until 10 now. 6 to 10 is when they usually do the testing window. And so what they do is, if they think that, if you don't have enough cortisol, you have really far-reaching effects, okay? And so, I mean, just a basis of not having cortisol alone, I mean, can be life-threatening, So, I mean, there's a primary condition called Addison's disease, in which your body does not make enough cortisol. And, so I mean, basically you have to be taking steroids during basically your life. And it's not unusual for mast cell patients either to have Addison's, or more commonly secondary adrenal insufficiency like I do. What happens in those conditions is, like, when you take steroids for a length of time or at a higher dose, it's sometimes hard to get your body to start making it again, because it's like these hormones are so, like, remember we were talking before about how it takes one time to change hormone cycling, right? So it's like when your body every day is like, oh, we already have cortisol here because it sees cortisol and it thinks that that's the same thing. When you stop it, it doesn't just automatically turn it back on again. It needs like weeks sometimes, and that can be very dangerous. And so that's why when you take glucocorticoids, or like cortisone or methylprednisolone or whatever, all of those things, once you've taken it at a reasonable dose, you have to wean down over time, and that can be a very slow process. And I mean, sometimes you can't get off of it. I mean, like, I was on 60 milligrams of prednisone a day for 5 months, consecutive for 5 months. And it was a nightmare. I mean, it was like I gained 40 pounds in, 4 weeks. And it was like, it was just awful. And I mean, it was like, I felt awful, but it was like, we didn't know what else to do. I mean, like, I was like, I was not doing well. And, my doctors are intelligent people, and, it was like, I was on board, but I mean, we were all just like, what are we gonna, I didn't know what else to do. I don't think there was a choice back then. you don't always have another choice. But when it's something that patients need to be aware of is that it seems to be, I would stand behind this, that mast cell patients are more likely to develop this because, this sort of dysregulation of cortisol because, mast cells, we talked before about how there's like all of these different glands, right, that affect, cortisol level, and there are several hormones that affect it, and some of those hormones are released by mast cells, and some of those hormones also can have receptors on mast cells too. So that means that mast cells are like inherently part of the system, right? And histamine also can greatly impact local levels of cortisol and ACTH, which is the hormone that tells your adrenals to make cortisol. So, so what does this mean? If you continue to have, honestly, if you have mast cell disease and are on a lot of medications every day or really don't feel, it's like, seriously, this is an easy test. It's like you can go and get, just a cortisol test, just show up the draw blood, whatever. I think it's between 6 and 10 in the morning. You have to do it at that particular time because because your cortisol level fluctuates over the course of the day. And then what they often will do at the same time is do what's called an ACTH stim test. So they'll have you arrive at like 8 or 7 or whatever. They'll draw your blood and then they'll give you an injection of ACTH, which is the hormone that your body makes that goes from the pituitary to the adrenals and tells your adrenals to make cortisol. And then I think it's like an hour and a half later, or 2 hours later, they draw blood again. And so what they do is they see, is the problem that your body doesn't, can't respond to the signal to make cortisol, or that it doesn't have that signal, or whatever it is, right? Because, so for those, for patients who have adrenal insufficiency where you're not making enough steroids, that's really important for daily management. It's also very important for emergencies like anaphylaxis. So a lot of us have, I have a port, and when I have anaphylaxis, I give myself medication, and I give myself obviously an EpiPen and everything as well. But one of the things that I do is, I have to give myself 120 milligrams of Medrol because, for people who have adrenal insufficiency, in an emergent situation, it's like it's not, can be life-threatening, and so the good news is that if you have adrenal insufficiency, it's fairly straightforward to manage in a lot of people. That's of course doesn't mean that it's always straightforward to manage, but I feel like there's a lot of a lot of misconceptions, I guess, about adrenal insufficiency. It's like the fact that if you're on prednisone, you're always going to gain weight, and that there are other things that you can take besides, steroids. Like if you have adrenal insufficiency, the only thing that is going to replace the steroids that your body does not make are steroids. And taking something else can kill you. Okay, it's like I see this every once in a while, on what else can I use to treat this? You can't. It's like you can't. It's like that is not. It's not going to be in your body long enough. It's not going to act as a stress hormone does. And so that's important. But it's also important to it's like it can take a while to really figure it out because everybody's body is different and everybody's endocrine system is different, right? Just once again. And so the big thing is with managing, adrenal insufficiency and mast cell symptoms, right? Is that as a patient, I'll realize now that it's if I, if I'm having really bad nausea or if I'm having really bad GI pain, I have to take extra steroids because pain increases the need for stress hormones. Stress hormones, like I said before, are also related to histamine and other symptoms and things like this. So it's not always super straightforward, but it's not. It's possible. You know what I mean? It's something that takes some time, but you certainly can learn about it and improve your life by doing it. And I also just want to be clear about the fact that adrenal insufficiency is not the same thing as adrenal fatigue. And so as far as I understand, adrenal fatigue is basically the same concept, but without tests tests that demonstrate that it's really there. So a lot of the same symptoms, and I'm not saying that it's not real. I just haven't seen anything that sort of would distinguish it from adrenal insufficiency, and unfortunately, this is the only way that I know of right now to diagnose adrenal insufficiency is with these tests. So I wouldn't. It seems like much more of like a homeopathic term, I guess. So yeah. But yes.
Two questions. One relating to that. How long can you have that? Will it kind of adjust itself if it goes untreated for years?
Yes, sometimes. Unfortunately, there are people where it's not discovered until they have some type of serious medical event, and the patient is not recovering, coma or something like that. So yes, I mean there are people where it can be low. I mean have low hormone production for several months at a time, and depending on the type of life you lead, even for years, but the real risk is actually not like a sort of day-to-day, it's like in an emergency. Like if you have anaphylaxis, you get hit by a car, or if you get, you know what I mean, or, something, God forbid, your mom, gets whatever. I mean, like some major event in your life, either physically or emotionally, when your body needs to have that, like that, it needs that stress hormone, it's not there, then it becomes very hairy very quickly. Yeah. So for people who have, I don't know my words launched to it, because I'm a bad patient. Don't tell me if I'm on this. It says, if you have like adrenal insufficiency, it literally says adrenal insufficiency, use steroids. It's like that's what it, you know what I mean? It is like because basically like if somebody happens upon you and you're in some type of like emergency medical situation, like no matter what, you need steroids. Like if you have Addison's disease or secondary adrenal insufficiency. And it's really important too for mast cell patients. In general, we have this sort of, our need for steroids is different, right, than most people. And so, there's this sort of like, folk tale in the mast cell community that the reason that, you have to go to the emergency department after you use an EpiPen is because it's so dangerous that, you have to go and they have to, it's like, okay, this isn't Pulp Fiction, okay? It's like, that's not what happens here, guys, okay? You go because you could have rebound anaphylaxis or you could have biphasic anaphylaxis, where just, you start giving anaphylaxis again without being re-exposed to the same trigger, either because your medication is wearing off or because, your disease hates you. But one of the things that is really important is that you also need, patients often need additional medication, right? So it's like you go to you give yourself an EpiPen, you call the fire department, whenever they come, they take you to the hospital, they watch you for a while, you should ideally get, IV Benadryl, IV Pepsid is sort of it's in dispute whether or not you definitely need an H2 antihistamine, IV antihistamine, when you've had anaphylaxis. I think it's solidly in that it's not going to hurt. Like it's either going to help or do nothing. Is what the data looks like to me. But so for the most part, like if you look on like your the TMS like emergency support, it's like it has IV famotidine is on there, and then IV Solu-Medrol, which is a steroid, so 125 milligrams typically of IV Solu-Medrol. Or whatever the dose equivalent is. And then when you leave, most mast cell patients will, not most mast cell patients, most anaphylaxis patients get a 3 to 5 day taper for steroids to decrease down their dose. For mast cell patients, it's more complicated. It depends how often you have anaphylaxis and if you take like daily steroids and things like that. I was going to say something about I can't remember it now. No, I do remember. So for people who react to alcohol, you should know that most of the formulations for glucocorticoids, the IV formulations and some of the oral formulations have alcohol in them. So for patients who go to the hospital and they're like, I have anaphylaxis, things were going great, they gave me meds, and I started, you know, I felt really sick. It's sometimes because there's alcohol. So, I think it's triamcinolone. I'm trying to think. I think it's triamcinolone, one of my patients uses, really intolerant of alcohol. And so she does that instead of getting IV. And then we have another patient that you can get it compounded actually, and it doesn't last for long, but it's not, I mean, it doesn't, neither does, you know, that's why you use like they come in those vials, you know what I mean? It's like when you push it in and it mixes the water or whatever, it's like they don't live for much longer either. But so that's if you're somebody that's in that situation, or if you're somebody who, you know, is, you know, if you discover that you're adrenal insufficient, you need to have prednisone. Then if you react to alcohol, you may need to have prednisone compounded to make sure that you have that with you, both for your daily doses, but also for emergency if you react to alcohol. Yes.
2 questions.
Yeah.
First of all, I have a 13-year-old. We just recently did biopsies on GI thinking that.
Yes. Okay.
And then got a wonderful GI.
She's okay. She is. She's great. Abrams is great. We have a huge overlap. It's like the Lisa Klein, Stephanie Abrams Society of like mast cell patients.
No, she's
Yeah, no, she's great. No,
seriously. So,
Yeah.
he has been off of gluten, casein, soy, corn, yeast, phenols, food colorings, and low histamine diet for over 3 years.
Okay.
Now he's really had it.
Yeah.
And genuinely,
It's a teenager, yeah.
he just turned 18.
Yeah, right, yeah, that's what it happens.
Yes, exactly.
Yeah.
And we're trying to add food to his diet, but we're having, you know, we just started, he was on ketotifen, we started Zylol, and is it gonna work, in your opinion?
I mean, it's like, yeah, I mean, it might.
Tired.
Yeah, I know. I mean, so let's sort of walk this back a little bit. Okay, so we were talking before about the idea that mast cells are very adaptive to the signals they have, right? So one of the nice things is that in your GI tract, you know, your mast cells aren't going to live in as long in your GI tract as they do just in other parts of your body, and you shouldn't ideally have. I mean, you should have some mast preservation in there, but I mean, if it's been a few, I mean, does he up until this point, like, have his GI reactions been managed? Like, is his disease been well managed?
We're managing it, but again, we just started.
Well, so but before this started,
Yeah.
were his GI symptoms pretty good?
Before myself.
Okay, so even with the food being removed, it was still bad.
It was better than what it was, but it was bad still.
Okay, so if he, you know, I mean, part of the food is one of those things. It's just like it's so culturally important, you know, and it's something that we see, you know, I mean, in American culture, and I mean, in many other cultures around the world, it's like something that we do like with our families, and you know, it's like it's comforting to us, and you know, it's really hard. I mean, like for years, I mean, it was like I would eat 5 things. Like I went to China, okay, and literally, do you know what I ate in China? French fries. Because you can't put anything else in French fries. You got potatoes, you got oil, and you got salt, and that's it. Okay, nobody is like revolutionizing French fries, right? And you know, I mean, like I know it was awful. I mean, like when we would go out like for dinner with my family, it was like we had like 3 restaurants, and they all served mashed potatoes and French fries, and it's like that's what I would get, you know. And but it's also it's hard too when they, you know, when there's not like an obvious thing where it's like I took away dairy and you didn't, you know, and like didn't get much better.
Yes.
And did you?
I mean, his rashes,
Yeah.
his all that stuff went
Yeah.
away. His eyes swelling a lot of blue.
Okay, so those things are
They
good.
went away.
But his GI symptoms were still not great.
Still, yes.
Yeah, so I mean, could it work? Yeah, it could work. I think that, I wouldn't assume that it wouldn't work, but I mean, in the same way that all mast cell patients have to do it, they have to do it slowly, okay? And it's funny because, you know, we were actually, you know, talking about the fact that, you know, Dr. Abrams and I have some different philosophies about how to food trial. So, you know, but about like, you know, just like how to introduce things. I personally have good success with, you know, and again, it's like, I am not your physician. I mean, I am not a physician. It's like, you should, you know, when Lisa Climate says things, those are things for you to talk to your providers about, okay? You know, do not ever, you know, send Dr. Abrams or anybody else, Lisa Climate from MastAttack says blah, 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 because that happens sometimes, and please don't do that to me. And, but in my experience for kids who have had really severe food reactions, what we have had decent results with doing are doing, so for 3 days, we do one small dose of the food, and we do Benadryl in the morning and night, and do the same thing for the next 2 days. And then on day 4, we don't give Benadryl, and if they tolerate the food, then pretty much they tolerate it, and if they react, then it's not something that we're like that the patient's tolerating enough to continue, and so we pull it and then we start with something else, and try with something else. So, but it depends a lot on this. Something else that's also really, really important here is that a lot of children who have mast cell disease have metabolic disease or MITO or like inborn errors of metabolism, and that is more often, in my experience, the bigger issue. And you know, in that, unfortunately, I mean, it's you know, if you have children who have metabolic disease, if you can get, you know, whole exome sequencing, get it. I mean, it's like, this is one of the few instances where it's like super expensive test that is actually worth it, you know, because it can give you answers to things that we can't. And it's just one of those things that, you know, that there is a way to have it, you know, you can find out. And of course, it's like, is there possible for them to have conditions that aren't represented there? Of course. You know, but you know, I mean, I've had some kids who were pretty sick that were, it was like, I have no idea. Like, I have no idea. Like, nothing. We've done everything. I have no idea what else to do. And, you know, we've gotten some answers from us where, I mean, it's like these kids have, you know, I mean, it's still, I mean, have, you know, require chronic medical management, but it's not, you know, you're not afraid all the time, right? I mean, it's much easier when you're at least not afraid to feed your child or yourself, you know? It's like, I like to live like that. It was my life for years, you know? And I definitely don't, you know, I would, you know, try to steer people clear of returning to that. So is it possible to work? Sure. But I would be very clear with yourself, though, that it's not going to work if he's not transparent. Like, you know, you have to be able to trust him that he's going to do this process, right? And if he doesn't, the only thing that he's going to be hurting is himself, you know? Because I mean, it's like, because then you're never going to know, you know? Because then you're upright. I know, and it's hard. It's hard, and this age is hard. And unfortunately, like, you know, this is the age where, you know, disproportionately, there's greater risk for, you know, for anaphylaxis at this age because, you know, they're 14 and don't want to carry their EpiPen around and you know, and don't want to tell their friends mom that they can't eat gluten or whatever, you know what I mean? It's a hard, I mean, like, let's be real, 13 is a hard year. It's a hard age for anybody, for any word, and you know what I mean? It's hard, but there actually are some decent support groups that are like parents of teenage anaphylactics. I can't remember exactly what they're called, but I'm sure that it's like, you know, it's people who deal with this sort of thing, and they have, the word. They like mentors, like, you know, like kids in like college age kids that like often will talk to like the teenagers and stuff. So if you could find something like that, that might be helpful. Or just other, I mean, like we have kids in our community that have, I mean, I know now we're, you know, 22, 23, 24 that might be, you know, interested in talking to younger patients too.
One more question.
Yeah.
Would mast cell cause osteoporosis?
Oh yeah, absolutely, for sure. Yeah, absolutely. Yeah. That's actually in systemic mastocytosis for men. That is not infrequently the condition that leads them to diagnose systemic masto is the osteoporosis, because it's, I mean, like 30, 40-year-old men and women too. So yeah, bone dysmetabolism is a very big issue in mast cell disease generally. You can also cause osteosclerosis, so it's like too much bone in certain parts. I've only ever seen that with systemic masto, true systemic masto. And osteolysis is when like you have basically so much of your bone is deteriorated that it like ruptures the bone, so it's just like a break. That's also, I've only ever seen that in true systemic masto. That's a marker for very aggressive disease. But Osteoporosis is much more common for systemic masto, and I would feel comfortable saying at this point that that is also a risk for MCAS. I mean, there's not like a study on it, but it's for MCAS patients are also at risk of osteoporosis. Yeah, it has. So if you have MCAS, or if you have, systemic masto or any mast cell disease, and are over the age of 30, I would ask for a DEXA scan. So it will tell you. Unfortunately, that scan is fairly common for us, and to track that every 2 to 5 years. Yes.
I have MCAS and I have osteoporosis. I'm unfortunately for the second time.
Yeah.
What do you do?
Yeah, it's unfortunately there isn't. There are some instances where they keep people on what's it called? They use calcitonin. That's something else. I think that's you know what? Do me a favor. Write down your email address and your question about what do I do with MCAS osteoporosis, and I'll message you about that. There's a specific medical treatment I'm thinking of. I actually can't remember the name of it right now.
Does exercise work with that as well? Like you always hear weights for osteoporosis.
Yeah.
So we should.
But you also want to make sure too. Most mast cell patients have low magnesium. And that also has, magnesium has 2 positive charges called divalent cation, and the di meaning 2 positive charges. And calcium also has 2 positive charges. And there are some instances where in certain parts of the body, if one is not available, it can affect the availability of another. So you definitely want to make sure that you have normal calcium. And you also want to make sure that you are supplementing vitamin D. This is so important because if you do not have enough vitamin D, your body's not going to be able to, to build your bones properly. And mast cell patients are almost universally deficient in vitamin D, and there's a lot of reason for that. A lot of different reasons, not like one conclusive thing, but your body uses vitamin D3 basically to mature mast cells. So we're pretty much all, and so another thing too, when we're talking about this, is that there's this medical myth that there is no IV form of vitamin D3 or vitamin D, but that's just not true because there's IV calcitonin. And so for patients who cannot take oral meds or by G2 or whatever, and they can only take it, by IV, you can, calcitonin is a form of vitamin D. So you want to make sure that you're tracking your vitamin D. And another thing too is that I didn't realize, for several years, how, I knew my vitamin D level was low, but I didn't realize how many of my symptoms were caused by low vitamin D. I had no idea. And so, it really was are you kidding me? I could have taken, 2,000, international units of vitamin D3 a day. So one of the nice things about that is that there are tons of sources for vitamin D3. If you have really stringent food allergies and stuff, you can typically still find them. Or you can there's prescription vitamin D2, which is, in mast cell patients, I find is not as effective as taking different doses of D3 because you have to metabolize from one into the other. But yeah, so vitamin D3, you want to make sure that you've got enough of that too because that will also affect your bone density.
Lisa.
Yes.
Oh,
yes.
Could you mention anything about vitamin K2 as well as vitamin D3 as far as, I recommend doing both to help actually get your D3 where you need it to be. But I think it would be hard to find an MCAS patient who's not, having bone issues because not only your diet's limited, so then your intake is limited. So then you have to find a safe vitamin source that you're not reacting to. Exercise issue.
Right, and they all have, vitamin K obviously most famous for clotting and bleed. Right, how many mast cell patients? I'm sorry. Yes, you're right. Yes.
Right. Do you mind also talking with this group here about compounded meds? How to get your compounding pharmacist to be a partner with you with regards to what filler you're using and what capsule. And also, do you have any referrals for people in the room on how to get it medically covered?
So, I don't,
He's a pharmacist.
yeah, you actually might be, I mean, you actually may have more experience like with, so I grew up in Boston, which I'm like, one of the things that like we're pretty spoiled about is the fact that Massachusetts has laws that specifically protect food allergy patients, and like allergy patients in terms of like getting things covered, compounding medications, and like standards of care and licensure. So, I mean, like, I do need to get things compounded, but it's definitely not as difficult as like it is in, you know, but I mean, a lot of it, like, our stuff isn't covered. I mean, we're talking about this earlier, talking about, you know, the IV medical shortage. Like, I found a pharmacy that literally, I was like, if I run interference with the board of pharmacy, will you make me compound IV medical for me? If like, I'll pay for all your expense, everything. And, you know, they agreed to do that, but it's super time consuming. And, you know, but this is the pharmacy also that like they make a ton of it. Like they're one of the pharmacies that will distribute it like all over the US and stuff. They're called Johnson's Compounding and Wellness. They're pretty good. They have very good understanding of mast cell disease. But that's largely because they've partnered with Brigham and Women's in the past, which is like if you're gonna be seen at a hospital, you know, in the US for you know, for mast cell disease, like it's, you know, one of the best I've had. But so do you have like, Amy, do you have any recommendations?
So just a little bit of background. I'm not a pharmacist, but my son is almost 4, and we've been compounding his meds since he was 6 months old. Honestly, a lot of it is luck. My husband's work has, we got our insurance through his work, and they gave us a concierge service, like a case manager. And he told her last year, at the very beginning of the year, your #1 job is to get our meds covered. And he's like, that became his baby. Like, we're gonna get the money, not only have everything covered, but we're gonna get money back for every dime spent on meds. And that was like our Christmas gift last year.
Yeah.
She did
It's a
it.
good Christmas gift, yeah.
Yeah. So but like, what does that entail? It entails like a giant corporation giving you a case manager who has time for that. I mean, like,
it's nuts.
It's hard, but it's doable.
Yeah, so Express Scripts does have, you know, most of the large pharmacy organizations, if you call and say to them, I'm repeatedly having the same problem, not necessarily about compounding, but I had this major issue where it's like I take Zofran 3 times a day, every day, no matter what, I've been taking it for years. And no matter what, my doctor would send over a prescription for 270 tablets with 4 refills, and no matter what, they would send me a prescription for 27 tablets with 40 refills, okay? And this would do, and no matter what, right? And I mean, I'm talking, this was like 4 years of my life. And every time I talk to somebody, they're like, oh, well, this isn't gonna happen this time. It's like, really? Because I talked to John 2 days ago, you know what I mean? It's here, and it's not, you know, and like stuff like that. And for me, what allowed me to sort of like get to this, like, you know, this like, you know, super secret, like, you know, case manager division or whatever, is the fact that I kept saying, I am having the same thing happening over and over again, and I'm tired of the same, like, how do I make it something change, okay? So sometimes that helps, but one thing that I will say in regards, not just specifically to getting, you know, meds compounded, or you know, just sort of more to getting care in general, is to have a script and to not expect healthcare providers to know more about your disease than you do, okay? And so I see this a lot, and I understand, I mean, like, I was diagnosed, I mean, when I was diagnosed, I didn't know anything about it either, and I mean, yes, it was very frustrating. I'd end up in the emergency department, and they wouldn't know what to, I was scared, you know, I mean, like, I didn't know what to do either. And, you know, there are something like 7,000 rare diseases affecting people in the US, okay? And so, you know, when you go to med school, you don't learn about all those, and especially, and I mean, it's like, in fairness, I do think that medical education is getting better, you know, but it's like you have to approach this as, you know, this isn't an argument. We're not fighting about this. It's not like you're fighting against them for your care. You are trying to improve your care with their help, okay? And, you know, I know that when, you know, you've been mistreated, and I mean, and, you know, it's like, I get it. I mean, I do. You know, I mean, like, you know, I wasn't always Lisa Klein, I was subject matter expert in mast cell disease. I mean, it was like, I know what it's like to be you know, I mean, I was a patient for several years before like I really understood my disease well, and you know, and for the years before that, I was just really sick and I had no idea what was wrong with me, and constantly seeing people were telling me that I'm a woman, so it must be anxiety, and you know, all of these things. But like my recommendations for anything are to have a script, okay? And so I actually have a post on this in the 107 series that's like, I don't know, it's like how do I talk to providers who don't know about mast cells, something like that. But yeah, so if you just Google MastAttack 107 series, how do I talk to my or something, there's like specific guidelines for that, okay? And a lot of it is just practice, you know, and it's just like, you know, it's okay to be upset about the fact that you have mast cell disease and angry, and it's okay to be frustrated. But it's important to remember that the fact that a provider doesn't know about that is not, you know, doesn't mean that they don't want to help you or that they won't want to learn about it, you know what I mean? So it's like nobody likes to be told how to do their job. Nobody likes to be made to feel stupid on either side, right? I mean, either like their job to treat your disease or your job to live with it, you know? And that's part of it. And so honestly, like when I really like was getting to a point where it was like, okay, this is like, the stakes are pretty high now. I literally wrote out a script and I would say this script, like before I went into like a meeting, you know, with my providers, and it made it much easier, you know, to like, you know, like I would like role play responses and like stuff like that. And at least then, because it's not like I wasn't coming from like such an emotional place, you know what I mean? It made it a little bit easier for me. But one more thing I will say regarding compounding medications is that if you have not tried a compounded medication, you have not failed that medication yet, okay? Yeah, so when people are like, you know, I failed every medication, and they've, you know, gone through all of them, and it's like, so how many of them did you compound? How do you compound any of them? Okay, go back to the beginning and start compounding them from there. You know, I mean, it's like compound H1, H2, you know, mast cell stabilizer, I mean, especially for ketotifen, because it's basically can only get it that way, you know, at this point in the US.
I'm so happy you said that, but I would take it further to say it may be the way you're compounding it. And I've had this experience as a practitioner where my patient's reacting, and then we figure out, oh, let's change it to rice bran flour. We've got to change it to a tapioca capsule. We've got to, so just because then you think you're failing the compounded formulation, but actually did you have a dialogue with your compounding pharmacist? Get to know them. If you're a parent, show them pictures of your kid. Same thing with your case manager. Send pictures of your kid. If you're an adult, send one of your grandbabies. And believe it or not, because they are not seeing you as a person.
Of course. Yeah, no, that's great.
I have watched this with my family members who have rare disease where you are a note, like you're just some piece of paper.
Yeah.
And then you say, oh really? You don't have what they, well my doctor said they were sending it. I'm gonna go and page the doctor. Oh look at that, I have it.
Yeah.
And okay.
Yeah.
So
yeah, no, that's great.
Maybe above that at all.
Yeah.
But you want to show off pictures of your child or grandchild anyway. So.
Okay, hold on just 1 second. Sorry. Yes.
So with the compounded meds, my daughter's is nothing but water and meds.
Yes.
And she was reacting to the water.
Yeah.
So we had to like.
Was it hospital water or you just had to get it?
We ended up.
Oh, this is when you were bringing the gallons of water, right? With you to the bar.
No. Well, I mean, yeah, we were doing that for a while when we were doing compounded formula in our room, but this is for the meds. And she started reacting with sterile water at med compounders. So what we ended up doing is giving. Yeah, we have to use different water.
Yep.
And I mean, we thought we were failing all the meds.
Of course.
I remember. I should react to every single med at the same time.
Right.
It wasn't it. But
just one thing that we did with the case manager, which helped, was we made we wrote out a lot for her to present to the insurance company why it would be less expensive for them to cover the meds than to cover a hospital stay.
That's a great idea.
So what it is, it's about the money. Like our case manager has a picture of my son, for sure, but like the people at Express Scripts don't care about us, but they do care that if they don't spend the money on this medicine, that we're going to be really expensive for them. And it was like a lot of data of like this is the numbers.
Yeah, that's what I did for the diabetes, medically triggers a lot. And so I did the math and showed about 300,000 are at risk for this.
Yeah.
And so that I calculated the cost of the Zolor injections to be over like billion.
Yeah, right.
But it was like 7 billion.
Yeah.
So,
It's a
like,
good idea in theory, but in business, it actually doesn't work like that because the budget comes from another place.
Yeah.
For emergency care and, you know, preventative medicine.
But it depends on, it depends, I mean,
Still,
in the,
sure,
but that's right, I mean, I think that in the US, it's, the budgets are different, but it also depends upon, the relationship that like the employer has with their insurer, because I mean, like, I was in pharma for a number of years, and so I mean, it was like, we had, like, I got all of our insurance for free, I got my chemo for free, you know what I mean? It's like, it's not, you know, it's like, we don't have one system in the US, it's definitely, most people have one system, but like in other parts of the world, the sort of thing that you're talking about here is like, that makes it much easier to directly influence care. You know what I mean? Because that is from one source. It is from one ministry. You know, especially in European countries too. So that's worthwhile to consider too. Yes, we should wrap up. Okay, so I'll hang out outside somewhere for a few minutes. I gotta push some meds and then I'm happy to hang out for a few minutes.